మీరు కనుక ఫస్ట్ టైం మా ఛానల్ చూస్తున్నట్లయితే లైక్ చేయండి, షేర్ చేయండి, కామెంట్ చేయండి. ప్లీజ్ సబ్స్క్రైబ్. మేము అందించే లేటెస్ట్ వీడియోల నోటిఫికేషన్ కోసం పక్కనే ఉన్న బెల్ బటన్ని ప్రెస్ చేయండి.
Hello friends, I am Dr.Shakuntala, Senior ENT Consultant and Director of Sri Rama ENT Care Center, Hyderabad. Today I am going to speak to you about a topic which is of foremost importance to us in our day-to-day life. This is called as obstructive sleep apnea. So what is obstructive sleep apnea? Basically, we spend 1/3 of our daily life, that is out of the 24 hours, we spend 8 hours in sleep. So conditions where there is disordered sleep leading to a partial or complete collapse of the upper airway and which leads to snoring or at times difficulty in breathing and apnea is called as obstructive sleep apnea. So what is the pathophysiology of obstructive sleep apnea? So basically upper airway consists of our nose, the nostrils, the chamber, air chamber behind the nose which is called as nasopharynx, the oral cavity and the chamber behind the oral cavity which is called as oropharynx. Then we come to the upper part of the airway which is called as the hypopharynx and then the larynx. So from the nose up to the base of our neck, this whole air passage constitutes the upper airway. So when there is a partial or complete obstruction of this upper airway, this leads to decreased airflow in the upper airway. So this leads to a condition called obstructive sleep apnea. So the reasons could be many. For example, there may be some mechanical obstruction in the nose. For example, a deviated nasal septum or a turbinate hypertrophy or polyps in the nose which obstructs the air entering from the nostrils to the back of the nose. Once the air negotiates that passage, next it comes across a structure called as the soft palate. The soft palate is present as a partition wall between the nose and the mouth, the oral cavity and the nasal cavity. So this soft palate is basically a muscular tissue covered by skin, and it is attached to the back of the hard palate, that is the bony structure which separates the nose and the mouth. So this soft palate sometimes can be very flabby, it can be very long, or it can be lax, or it can be very posteriorly located. In that case, it can lead to obstruction of the air entering the nose and then going into the back of the throat. And the other causes could be a very large tongue or a very thick tongue, or the base of the tongue, that is the back of the tongue, may be very bulky, and there may be some lymphoid tissue called lingual tonsils which obstruct the passage of the air behind the tongue. There could be other structures such as the adenoids which are present, the lymphoid tissue which are present in the nasopharynx, and the tonsils which are present on either side of the throat at the back. So the enlargement of the tonsils and the adenoids could also lead to the upper airway obstruction. Some other reasons, such as in the upper part of the airway, the corridors, that is the lateral pharyngeal wall, that can be very lax and that can come together and reduce the air passage in the back of the tongue, which is called as the oropharynx. Next we come to the upper part of the part between the mouth and the larynx, which is called as the hypopharynx. So here also there could be some velopharyngeal space. Next is a structure called as the epiglottis, which is present just above the voice box. That is basically a lid-like cover. So in some patients that epiglottis may be directed or angulated backwards. It may not be in an erect position, it may be directed backwards. And it covers the upper part of the voice, that is the voice box, the larynx, and covers it like a lid. So the air is not able to enter freely into the voice box, that is the glottis, and then into the trachea. So these are the various levels of obstruction which can happen. So in obstructive sleep apnea, what happens is that there can be a mechanical obstruction or a dynamic obstruction. So dynamic obstruction is basically when we sleep, that is when we lie down with our head position. Then in the sleep, that especially in the REM sleep, the respiratory drive falls. And when the respiratory drive falls, then the nerve stimulation to the muscles of the soft palate, the tongue, the pharynx, the lateral pharyngeal wall, so the muscle tone of these tissues reduces because of the decreased stimulus from the brain. And so these tissues tend to collapse like a funnel. a V-shaped structure. And when there is complete obstruction, then there will be complete blockade of this funnel, and for few seconds, say 10 seconds to 20 seconds, no air will pass from the nose into the lung. There will be complete obstruction in this area, and that is called as an apneic spell. So this happens in deep sleep in some patients. So when this happens repeatedly over a period of sleep of say 8 hours or so, then that can lead to a condition called as obstructive sleep apnea. So this is a severe form of snoring. So snoring is when there is only partial obstruction without any collapse of the airway such that there is fall in the oxygen saturation. But when the oxygen saturation falls below 100 and this kind of an apneic or hypoapneic episode lasts for more than 10 seconds, then this condition is called as obstructive sleep apnea. Now, what could be the causes? Like, who are the patients who are prone to this condition of obstructive sleep apnea? So first and foremost cause could be obesity. That is, patients who have a high body mass index, who have a very short and wide neck with a very big neck circumference. So there will be collapse of the tissues in the upper part of this part. The tongue will fall back, the soft palate will come down, and the pharynx muscles will also be very lax and the tissues will come together. Then there are other causes like severe hypothyroidism. Then there are some structural abnormalities where syndromic abnormalities where the mandible, that is the lower jaw, that may be very small in size, or it may be located posterior to the upper jaw, that is the maxilla. So because the mandible is attached to the base of the tongue, so when the mandible is situated back or it is very small, then the tongue tends to fall back when the patient lies prone, flat. So that can cause to obstructive sleep apnea. Then there are other conditions, for example, a patient who has a very sedentary lifestyle or who takes a lot of alcohol before going to bed, or is a heavy smoker. Even such patients, or even those, especially children who have very large adenoids and tonsillar hypertrophy, or when even some cases small children, newborn babies who have condition called laryngomalacia, where the epiglottis is also situated very posteriorly and angulated very posteriorly with short folds, so it closes the upper airway, the laryngeal inlet, and causes obstruction. So these could be some of the causes for obstructive sleep apnea. Now, what are the classical symptoms of obstructive sleep apnea? Most common symptom would be snoring, because snoring is a milder form of this condition. So severe snoring or loud snoring which can be heard across the room or disturbs the sleeping partner. For example, the patient is traveling and the co-passengers in a train or any other place in a vehicle also get disturbed due to the patient's loud snoring. So snoring is the most important, the foremost symptom of obstructive sleep apnea. The second symptom is the patient suddenly, while snoring, suddenly tends to become very restless, and there is a cessation of the snoring and the patient wakes up and then gasps for breath. And then suddenly he starts breathing again and then again falls off to sleep. So this happens repeatedly over a period of sleep. So this is called as an apneic spell. So this is the second most important symptom of OSA. The other symptoms, because of the disturbed sleep and because of the fall in the oxygen saturation and the repeated apneic spells, the patient will feel very tired the whole day, feel very lethargic, and will tend to fall off to sleep during the whole day. That is, while he's sitting on the chair at office, or the students who are in the classroom, they tend to just simply doze off because their sleep has been interrupted at night. So they tend to feel very sleepy and drowsy or tired, lethargic during the daytime. So there will be reduced work performance, lack of concentration, irritability, and long-term effects also leading to depression. Also, there will be some other dissatisfaction in the bed partner or marital discord as long-term effects of this condition. Now, what could be the complications of obstructive sleep apnea? Why is it so important, and why do we need to take this condition very seriously? So chronic obstructive sleep apnea can lead to hypertension. It can also lead to arrhythmias, that is irregular heartbeats or very fast heart, that is tachycardia. It can lead to coronary heart disease. It can also lead to heart failure, and in some cases it can lead to sudden myocardial infarction or heart attack during sleep because of the fall in the oxygen saturation. That is, if the apneic spell lasts for very long, where absolutely no oxygen is entering the lungs for say 20 seconds to 30 seconds, that can also lead to heart attack during sleep. So these are the long-term and very scary complications of obstructive sleep apnea, which is why we need to give a lot of importance to this condition and take it very seriously. So how do we investigate a patient who has the symptoms which I mentioned above? So when a patient comes to OPD with these following classical symptoms, then as an ENT specialist, we need to examine the patient. So first we take a detailed history of how severe the problem could be, and then we examine the patient's height, weight, and calculate the body mass index to see if it is raised. We also measure the neck circumference of the patient, and there is a criteria for that in females and males. What should be the ideal neck circumference and what should be beyond that? What is beyond that? Also, we examine the nose to look for any mechanical obstruction like deviated nasal septum, turbinate hypertrophy, or polyps. Then we examine the throat. We look at the mouth opening. We check the position of the soft palate, whether it is very lax and it is hanging down, whether it is touching the base of the tongue. Is the tongue very bulky and very large in size? And can we see the back of the throat when the patient opens his mouth and says ah? We also check the position of the lower jaw, the mandible. Is it pushed backwards? Is it small in size? Then also we do a fibro-optic laryngoscopy to see whether there is any obstruction at the level of the hypopharynx, the position of the epiglottis. Then we ask the patient to perform a certain maneuver called Muller's maneuver, where the patient has to breathe against a closed glottis, and to see whether a negative pressure, when we create a negative pressure in the pharynx, whether the tissues are being sucked in. So once we have a fairly good diagnosis of the obstructive sleep apnea, and we can determine the level of obstruction, that is whether it is at the level of the nose, the soft palate, the oropharynx, or the hypopharynx, or the larynx, we subject the patient to certain investigations which we call as CT scan of the paranasal sinuses. Also an investigation called dynamic MRI, that is we ask the patient to visit the radiology lab when the patient is feeling very drowsy or sleepy after a heavy meal, and when he lies down on the gurney and he falls off to sleep and starts snoring, that is when the technician takes an MRI of the neck. At that time we can find out exactly which tissues are collapsing and whether the airway at which level, or is it multiple levels of the collapse of the airway. Is it happening at the level of soft palate, that is higher up, or at the level of the oropharynx or hypopharynx or larynx. So that is called as a dynamic MRI. A similar investigation which is done is called the drug-induced sleep endoscopy. So this is the final investigation for assessing the level of the obstruction. So actually it could be a single level obstruction or a multi-level obstruction. So during DISE, that is drug-induced sleep endoscopy, the anesthetist gives a mild dose of sedation to the patient in operation theatre, and sleep is induced. So the patient becomes drowsy, falls off to sleep, and starts snoring. That is when the ENT specialist introduces a fibro-optic endoscope through the nose and visualizes the entire upper airway right up to the larynx to see whether there is any collapse of the airway and at what levels is it collapsing. Is it an anterior-posterior collapse? Is it a lateral collapse? Is it a global collapse, that is throughout the whole airway is collapsing? For how many seconds is it collapsing and there is complete closure of the airway, etc. So all these inferences can be made out by drug-induced sleep endoscopy. There is one more investigation which is called as the polysomnography. Now this is to determine the severity of the OSA. So basically in a sleep lab, or it can be a home-based study also, the patient is connected to several monitors which measure the patient's level of sleep, the REM sleep, the non-REM sleep, his eye movements, his respiratory movements, then also his pulse rate, his oxygen saturation, and some other parameters which can measure, throughout the period of 8 hours of sleep, the recording will occur, and then we get a report which is called as the polysomnograph. So, or in other words, this is a sleep study test. So this will help us determine whether the patient has obstructive sleep apnea and whether it is a mild or a moderate or a severe obstructive sleep apnea, based on the two parameters, that is apnea hypopnea index, that is RDI. So an RDI of less than 5 is considered as mild, an RDI of 5 to 10 is considered as moderate, and more than 10 is considered as severe. So basically we measure the number of apnea or hypopnea spells which occur per hour over a period of 8 hours. We also measure the level of oxygen, minimum oxygen saturation, that is how low the oxygen saturation dips during the period of apnea. So these two important parameters can be deduced from the sleep study or the polysomnography. So once we have now determined the level of the obstruction and how severe it is, next is the intervention. So how do we tackle such cases? So such cases are actually, the treatment is multidisciplinary. So basically we ask, if the patient is obese, we ask the patient to lose weight, then lead an active, physically active life, do exercises, then also to avoid smoking, cut down his alcohol intake, especially we instruct the patient not to drink before going to bed. We ask the patient to take a very well-balanced, nutritious diet, and we also, if he is suffering from, say, diabetes or hypothyroidism or hyperlipidemia with altered cholesterol levels, then we ask the patient to consult a physician and get these corrected. Then moreover, we ask the patient also to see whether, he has any, if there is some problem in the nose, for example, he has allergy or polyps, or there is some mechanical obstruction like deviated nasal septum and turbinate hypertrophy, we subject such patients to corrective surgery for the nose. As far as the airway, upper airway, that is the soft palate, the tonsils, adenoids and the pharynx and the larynx is concerned, if it is a mild case, then we put the patient on CPAP, that is continuous positive airway pressure. So the CPAP machine will basically forcibly, it will push in air into the airway and keep it patent. It will prevent it from collapsing, and thereby it will reduce the episodes of apnea. So the patient will have a good sleep, undisturbed sleep, the oxygen saturation will be maintained, and the patient will feel very fresh in the morning. So his work performance and his other symptoms like lethargy, daytime sleepiness will also disappear, and he will feel much better. So this is the gold standard treatment. But why do we not only recommend CPAP? So CPAP is basically only indicated for those patients who have morbid obesity, contraindications for surgery, who have severe obstructive sleep apnea, and those who cannot undergo surgery because of their general condition, their age or their other comorbidities, or because of their excessive weight. So CPAP is the only alternative. So we prescribe a CPAP as machine as the first and foremost device to take care of the apnea, and then if surgery is feasible, some kind of a corrective surgery, and then other adjunctive measures like weight loss, leading a healthy lifestyle, having a proper well-balanced diet, doing exercise, reducing alcohol smoking. So we simultaneously prescribe these measures. Now, what are the surgeries which can be done for the pharynx to correct the obstructive sleep apnea? So primarily because this is an upper airway condition, so there are certain surgeries which can reduce the snoring and which can bring down the obstructive sleep apnea the degree from a severe to a moderate or a mild case. I'm not saying that we can take care of it 100%, but definitely we can reduce the symptoms and provide the patient a healthy lifestyle. So basically the surgeries will involve the soft palate. So if the soft palate is very lax, then there are certain palatal reduction procedures or palatoplasty or pharyngoplasty. If the tonsils and adenoids are enlarged, then adenotonsillectomy is advised. If the base of tongue is very bulky, then midline of the base of the tongue can be reduced by radiofrequency or coablation channeling, or by certain tongue-based reduction procedures. Or there can be some other surgeries, for example, hyoid advancement or mandibular hyoid advancement, which will push the tongue forwards and increase the gap behind the tongue, that is a retrolingual space. So that will also increase the gap in the upper airway. Then also epiglottopexy or epiglottoplasty, that is epiglottis which is tending to fall back, that can be also reduced in size, and it can be shortened and straightened. So these are the various corrective surgeries which are done by the ENT surgeon when the case of obstructive sleep apnea is moderate to severe and cannot be corrected by conservative measures. We also prescribe certain medicines. For example, if the patient has nose allergy, then we give intranasal corticosteroids and antihistamines to take care of the patency of the nasal cavity. So my friends, I have given an overview of obstructive sleep apnea, how to diagnose it, why is it important and why is it relevant in our present day life, what could be the symptoms, the possible complications if we ignore it, and how to approach a doctor, preferably an ENT surgeon because it deals with the upper airway, and what could be the corrective measures, that is the conservative measures and the surgical measures to take care of this problem. Thank you.